Hello everyone, today we are going to talk about pathology of the oral cavity. I am Dr. Saida Khadija Fatima, Assistant Professor, and we'll start with the normal structure of the oral cavity. Oral cavity is the point of entry for digestive and respiratory tracts. The mucous membrane of the oral cavity consists of squamous epithelium. This squamous epithelium is either keratinized and non-keratinized depending upon the areas. So, epithelium is keratinized over hard palate, lips, and gingiva, while elsewhere it is non-keratinized. Subepithelially, there is a vascularized connective tissue. Underlying the mucosa is the muscle layer. There might be non-specific inflammatory cells present at the junction of the mucosa and the connective tissue stroma. Mucous glands are nothing but minor salivary glands are scattered throughout the oral mucosa. Sebaceous glands are present in the region of the lips and buccal mucosa only. Lymphoid tissue is present in the form of tonsils and adenoids. We'll be discussing about developmental anomalies, mucocutaneous lesions, inflammatory diseases, tumors and tumor-like lesions of the oral cavity in this chapter. The developmental anomalies of the oral cavity are facial clefts, Fordyce granules, leukoedema, and the developmental anomalies of the tongue. Facial cleft includes cleft upper lip, which is also called as hair lip, and cleft palate. These two occur because of failure of fusion of the facial processes. Fordyce granules are symmetrical, small, light yellow macular spots present on the upper lip mostly and also inside in the buccal mucosa, and these are nothing but a collection of sebaceous glands. Leukoedema is an asymptomatic condition occurring mostly in children characterized by symmetric gray-white areas on the buccal mucosa. Histologically, there is pronounced intracellular edema. Intracellular edema is nothing but between the squamous epithelium there might be edema that is also called as spongiosis, and there is no increased malignant potential compared to leukoplakia. So leukoplakia is nothing but white patch. Leukoplakia and leukoedema can be confused because of the white color, but we can differentiate it histologically. The developmental defects of the tongue includes macroglossia, which is due to lymphangioma, that is dilatation of the lymphatic vessels, and hemangioma, that is dilatation and proliferation of the vascular vessels, and it also might be sometimes due to amyloid deposition. Macroglossia is mostly associated with anomalies like Down syndrome and mental retardation. Microglossia is reduction in the size of the tongue. Aglossia is absence of the tongue. Fissured tongue or furrowed tongue or grooved tongue is also another developmental defect. Bifid tongue is a rare condition occurring due to failure of two lateral halves of the tongue to fuse in the midline. Tongue tie occurs when the lingual frenum is quite short or when the frenum is attached near the tongue tip. This is a patient with a macroglossia. This is a patient with microglossia. This is fissured tongue, bifid tongue, and tongue tie. Stomatitis is nothing but inflammation of the mucous membrane of the mouth. It can occur in course of several diseases. Aphthous ulcers, canker sores are one of the types of stomatitis. It is the commonest form of oral ulcers. The cause is unknown but may be precipitated by emotional factors, stress, allergy, hormonal imbalance, nutritional deficiencies, gastrointestinal disturbances, and trauma. It is characterized by painful oral ulcers not more than 1 centimeter in size. Recurrent aphthei may form a part of Behçet syndrome and inflammatory bowel disease. Herpetic stomatitis is caused by herpes simplex virus. It is an acute disease occurring in infants and young children, and it is the most common manifestation of primary infection of herpes simplex virus. The lesions forms vesicles mostly inside the hard palate or around the lips. Similar lesions can appear on the genital areas as well. Necrotizing stomatitis occurs mostly in poorly nourished children, like in kwashiorkor, infectious diseases like measles, immunodeficiencies, and emotional stress. All these reducing the immunity. The lesions are characterized by necrosis of the marginal gingiva and may extend into the oral mucosa. So, this is a oral mucosa being involved. There is a gangrenous patch over here, that is because of cellulitis of the tissue of the cheek, which may convert into gangrene of the cheek as well. Mycotic infections are nothing but fungal infections commonly involving oral mucosa, which is actinomycosis and candidiasis. Actinomycosis is a normal commensal in the tonsils, but in event of reduced immunity, it can become a pathogen. Cervicofacial actinomycosis is also called as lumpy jaw. It is the commonest form of the disease developing at the angle of the mandible. Angle of the mandible is really close to the tonsillar crypts. So there is a close association between the actinomycosis, which is commensal in the tonsils, might become pathogen and involve the angle of the mandible. Candidiasis is also called as moniliasis or thrush in the oral cavity. It is caused by Candida albicans, which is a commensal in the mouth. It appears as an opportunistic infection in immunocompromised host. There are erythematous lesions on the palate. In immunodeficient patients or immunocompromised patients, such as in acquired immunodeficiency syndrome, there are certain oral manifestations which occurs because of opportunistic infections. It can be either due to fungal infections like candidiasis, histoplasmosis, and cryptococcosis, or due to bacteria causing dental caries and periodontitis. Mycobacterial infections due to Mycobacterium tuberculosis is also very common. Viral infections is because of herpes simplex virus and cytomegalovirus and human papilloma virus also. Tumors, mostly Kaposi sarcoma, which is a malignant tumor of the vascular compartment, and squamous cell carcinoma, non-Hodgkin's lymphoma are very common in AIDS. Others are hairy leukoplakia. Hairy leukoplakia is associated with Epstein-Barr virus in AIDS patient. Recurrent aphthous ulcers are also very common in AIDS. So this is a case of oral mycobacterial tuberculosis showing granulomas composed of epithelioid histiocytes, which are nothing but slipper-shaped histiocytes, and a rim of lymphocytes will be there along with Langerhans type of multinucleate giant cells, typical of mycobacterium infections. This is a case of histoplasmosis. The black colored arrow shows the multiple soap bubble appearance of the macrophages because of amastigotes present inside the macrophages. So you can see multiple macrophages with soap bubble appearance here. This is a H&E stain. This is a PAS stain showing the mucosa of the oral cavity comprised of stratified squamous epithelium. In the corneum layer, there are hyphae of PAS positive candidal elements. Here again we are seeing a squamous layer with acantholysis, that is separation of the cells from the epithelium as such. So this acantholytic cells are now showing multinucleated inclusions. So there will be monstrous cells can be there, or they can be abnormal nucleations of the cells with intranuclear inclusions. All this multinucleated multisegmentation and intranuclear inclusion points towards herpes simplex virus. So this is herpes stomatitis. This is again a case of viral stomatitis caused by cytomegalovirus, showing a prominent intranuclear inclusion. Coming to the classification of tumors and tumor-like lesions of the oral soft tissues, the tumor-like lesions are comprised of fibrous growths. These can be either fibroepithelial polyps, fibrous epulis, denture, hyperplasia. Pyogenic granuloma is very closely related to capillary hemangioma. Mucocele ranula are associated with dilatation of the mucus glands. Dermoid cyst is another entity. The benign tumors of the oral cavity include squamous papilloma, hemangioma, lymphangioma, fibroma, fibromatosis. Gingival tumors of minor salivary glands like pleomorphic adenoma can also occur in oral cavity. Granular cell myoblastoma. This is also a rare benign tumor. The premalignant lesions includes hyperkeratotic leukoplakia, dysplastic leukoplakia, and erythroplakia. Malignant tumors of the oral cavity, most common is the squamous cell carcinoma. Other malignant tumors like lymphomas can also occur in oral cavity, but they are very rare. So what is a fibroepithelial polyp? Fibroepithelial polyp is mainly because of constant irritation to the oral mucosa or chronic trauma, maybe because of the dentures in patients who are dependent on the denture. So these are composed of reparative fibrous tissue covered by a thin layer of stratified squamous epithelium. Fibrous epulis is again following trauma or inflammation in an area constantly. It is a lesion occurring on the gingiva and is localized hyperplasia of connective tissue. Denture hyperplasia occurs in edentulous or partly edentulous patients. Lesion is an inflammatory hyperplasia in response to local irritation by ill-fitting dentures or an enlarged tooth. So hyperplasia is nothing but increase in the number of the layers. So stratification will increase, and sometimes keratinization can also occur. Pyogenic granuloma. So this is an elevated bright red swelling of variable size occurring on the lips, tongue, buccal mucosa, and gingiva. So this is a vasoproliferative inflammatory lesion. That's why it was also named as lobular capillary hemangioma, but it is not a hemangioma as such. So this is this we are seeing is the mucosa of the oral cavity lined by squamous epithelium, and below the this might be keratinized because of the corneal mayhem present. Mostly this might be a lip. Then beneath the epithelium, that is subepithelially, we are finding lobular capillary areas. These lobular areas are composed of proliferating capillaries lined by plump endothelial cells, and intervening stroma is showing plump fibroblast. You can also see inflammatory cells here. Like I'm pointing out the multi-segmented neutrophils here. So all these acute inflammatory cells can also be present in the area along with extravasated RBCs. So this mostly favors pyogenic granuloma. Mucocele is also called as mucus cyst or retention cyst. It is the cystic dilatation of the mucus gland of the oral mucosa. The cyst often ruptures on distension and incites inflammatory reaction. So this will be surrounded by inflammatory reaction. This is the stratified squamous epithelium, and entire thing below it can be called as stroma, but here you are seeing a dilated mucus gland. This is the stroma here, the pink color. This is the dilated glands. If this is lined by a proper epithelium or true epithelial lining is present, then it is called as a ranula. So ranula is a large mucocele located on the floor of the mouth. Cyst is lined by true epithelial lining. The benign tumors of the oral cavity are hemangioma, which can occur anywhere in the mouth and when it occurs on the tongue, it may cause macroglossia. It is most commonly capillary type, although cavernous and mixed type may also occur. Squamous papilloma can occur anywhere in the mouth and has a papillary appearance of finger-like projections. So microscopically also you can see the finger-like projection here. Looks like a papillary frond with a fibrovascular core. So this is a closer view showing a fibrovascular core surrounded by baseloid cells. Then this, as you go in the upper layer, we can see some coilocytic change, which is nothing but cells with a perinuclear halo or clearing. So this is the coilocytic cell. So here we see in the basal layer we can see some mitotic figure as well. So the most characteristic feature here is the fibrovascular strand covered by the squamous epithelium. Lymphangioma may develop most commonly on the tongue, producing macroglossia, on the lips producing macrocelia, and on the cheek as well. The term giving to the lymphangioma on the lateral side of the neck is cystic hygroma. Cystic hygroma is a special variety of lymphangioma where you can see multiple dilated spaces of the lymphatic cavity lined by endothelial cells, and the center of the lumen will be filled by lymph. Sometimes you can find lymphocytes as well, and intervening stroma will be very scant. Tumors of minor salivary glands can be present in oral cavity, and most commonly the tumor occurring here is the pleomorphic adenoma. Granular cell tumor is a very rare tumor, and it is also called as granular cell myoblastoma because of its mesenchymal origin. This is a benign tumor, and the most common location is in the tongue, and it can also occur in other places in the oral cavity as well. So this is a low power view or the scanner view showing the mucosa lined by stratified keratinized stratified squamous epithelium with pseudoepitheliomatous hyperplasia. So you are seeing that the squamous epithelium here is not showing regular rete ridges, it is showing irregular rete pecs and some hyperplastic areas as well here. And subepithelially you can see hypercellular proliferation of pale cell which is arranged in the form of nest. Can you make out nests here, which I'm pointing out? So there will be nests, sheets and nest, and fascicles as well. So if you go take a closer look, these cells will appear polygonal in shape with a pycnotic nucleus pushed to one side, that is eccentric nucleus, and the cytoplasm is characteristically dense eosinophilic granular cytoplasm. Mostly this is because of the presence of mitochondria, excess of mitochondria in the cytoplasm. Oral leukoplakia is nothing but the white lesions. Oral leukoplakia may be clinically defined as a white patch or plaque on the oral mucosa exceeding 5 mm in diameter, which cannot be rubbed off nor can be classified into any other diagnosable disease. A number of other lesions are characterized by formation of white patches. However, from the pathologist's point of view, the term leukoplakia is reserved for epithelial thickening, which may range from completely benign to atypical and to premalignant cellular changes. The white lesions of oral mucosa includes the benign lesions, which is Fordyce granules, hairy tongue, leukoedema, lupus erythematosus, white sponge nevus, and the premalignant lesions of the oral cavity includes leukoplakia, oral lichen planus. Malignant lesions which can present as white lesion is squamous cell carcinoma. Leukoplakia, the sites of predilection in the descending order of frequency are cheek, mucosa, angle of the mouth, alveolar mucosa, tongue, lip, hard and soft palate, and floor of the mouth. In about 4 to 6% cases of leukoplakia, carcinomatous change can occur. It has the strongest association with the use of tobacco in various forms, like in heavy smokers and in those who chew tobacco containing products like pan masala, zarda, and gutkha. Other etiological factors implicated are chronic friction, such as with ill-fitting dentures or jagged teeth, and local irritants like excessive consumption of alcohol and very hot and spicy foods and beverages. A special variety of leukoplakia called hairy leukoplakia has been described in patients of AIDS and has hairy or corrugated surface, but it is not related to development of oral cancer. The morphological features of the lesions of leukoplakia may appear as white, whitish yellow, or reddy velvet of more than 5 mm in diameter and has variable appearance. They are usually circumscribed, slightly elevated, smooth or wrinkled, speckled or nodular. Histologically, leukoplakia is of two types. Hyperkeratotic is characterized by an orderly and regular hyperplasia of squamous epithelium with hyperkeratosis on the surface. Dysplastic type is when the changes such as irregular stratification of the epithelium, focal areas of increased and abnormal mitotic figures, hyperchromatism, pleomorphism, loss of polarity, individual cell keratinization are present. So dysplasia is nothing but disordered development or abnormal development. Normal mucosa might undergo hyperplasia because of increase in the layers, and then it can undergo dysplasia with disordered or abnormal development. Mild, moderate and severe dysplasia can occur. Severe dysplasia might convert into carcinoma in situ, which can invade the basement membrane, causing invasive carcinoma. Usually mild dysplasia may revert back to normal if the offending etiological factor is removed, whereas severe dysplasia indicates that the case may progress to carcinoma. So this is a normal stratified squamous epithelium with a basal layer, usually 2 to 3 cell thickness, and here there is this connective tissue stroma. Mild dysplasia shows an increase in the layer of the basal cells, and there will be disordered polarity of the basal cells with hyperchromasia, sometimes increasing the size of the nuclear cytoplasmic ratio, and mitotic figures can be present. Mitotic figures are generally present in the normal 2 to 3 basal layers, but if you're finding the mitotic figures in the upper layer as well, then it is favoring dysplasia. Moderate dysplasia is when 2/3 of the epithelium is involved, and these cells will show mostly be like the basaloid cells, but they'll again be with disordered polarity, hyperchromasia and increased NC ratio. Sometimes mitotic figure can also be seen in the middle of the epithelium. Severe dysplasia is the full thickness involvement of the epithelium, leaving behind some cornified layer. So here also you are seeing some mitotic figures and disordered polarity. Few cells are facing this side, few cells are in this direction. So that is called as disordered polarity. There is differentiation in the size of the cell, that is pleomorphism, along with mitotic figures and hyperchromasia as well. Erythroplakia is a form of dysplastic leukoplakia in which the epithelial atypia is more marked and thus has higher risk of development of malignancy. Coming to the malignant lesion of the oral cavity, which is the squamous cell carcinoma, the cause has strong association with tobacco smoking, chronic alcohol consumption, human papillomavirus. So tobacco smoking and tobacco chewing causing leukoplakia is the most common factor as discussed above. Chronic alcohol consumption can also cause SCC. Human papillomavirus infection, particularly 16, 18 and 33, can cause cervical squamous carcinoma. We have also read about the HPV involvement in the squamous papilloma, which is because of the benign strain, which is 6 and 11. So here the strains involved in the HPV is 16, 18, 33 and 35. Weak association can occur along with chronic irritation from ill-fitting denture or jagged teeth. Submucosal fibrosis, as seen in Indians consuming excess of chilies, can be seen. Poor orodental hygiene, nutritional deficiencies, exposure to sunlight, exposure to radiation, Plummer-Vinson syndrome characterized by atrophy of the upper alimentary tract can be associated with SCC. Gross morphological features of squamous cell carcinoma can be of 4 types. Ulcerative type is the most frequent type and is characterized by indurated ulcer and formed, everted or rolled margin. Papillary or verrucous type is soft and wart-like growth. Nodular type appears as firm, slow-growing submucosal nodule. Serous type is characterized by infiltration of or fibrosis into the deeper structures. Normally, the histological picture of or microscopic picture of the squamous cell carcinoma are nothing but nests of cells. These nests of cells composed of polygonal cells with a nucleus showing increased NC ratio with glassy eosinophilic cytoplasm, vesicular nucleus. They will be frequent mitotic figures. So these nests will be infiltrated into the stroma as well. The intervening stroma will be reduced. Some nests will form keratin pearls because of well differentiation. So that's called as well differentiated keratinizing neoplasms or well differentiated squamous cell carcinoma. So nests of tumor cells, stroma is reduced with proliferating vessels, and keratin pearl formation are the characteristic of squamous cell carcinoma. The histological patterns will range from well differentiated keratinizing neoplasms to anaplastic or poorly differentiated. Sometimes you can also find sarcomatoid, that is spindling of the cells, which have very bad prognosis. Typically, oral squamous cell carcinoma infiltrates locally before it metastasizes. The metastasis is mostly to the cervical group of lymph nodes, and you sometimes distant metastasis can occur due to uh, to the mediastinal lymph nodes, lungs, and liver. Histologically, it is classified into well differentiated, moderately differentiated, and poorly differentiated. Well differentiated is always based on the keratin pearl formation. Moderately differentiated is when the keratin pearl formation is less, but still the cells are in nests to be identified as squamous, and the cytology is also identified as squamous cell. So nest along with squamous cell, and very less or attempt to pearl formation will be there in moderately differentiated. In poorly differentiated, there won't be any nest formation, there won't be any keratin pearl formation, and there might just be sheets of cells arranged haphazardly. There will be marked pleomorphism, marked hyperchromasia, and abundant mitotic figures in poorly differentiated squamous cell carcinoma. In such cases, we have to do immunohistochemical markers to know the differentiation of the cells. There are different types of squamous cell carcinoma. Verrucous carcinoma is the well differentiated type. There won't be any cytological atypia, but it is a carcinoma which can be identified based upon the local invasion, the bulldozing appearance of the retipex. It is non-metastasizing, but local recurrences can occur, and this verrucous SCC can progress to proper well differentiated SCC as well. Papillary squamous cell carcinoma has papillary fronts along with all the other features of squamous cell carcinoma. It might be keratinizing and non-keratinizing time. It has a better prognosis than conventional squamous cell carcinoma. Spindle cell carcinoma, as I said, some spindling can also occur in sarcomatoid pattern. So this has very worse prognosis, and radiation induced tumors might be the cause. Carcinoma cuniculatum is well differentiated, locally destructive lesion with deep burrowing pattern will be there. So this is the epithelium, and suddenly there will be a burrow of tumor cells into the connective tissue stroma. Metastasis is rare in carcinoma cuniculatum. Basaloid type of SCC has basaloid cell with comedonecrosis pattern. There will be necrosis in the center of the basaloid nest. Then the cells will be particularly dark, small, round, basophilic with scant cytoplasm. There will be frequent metastasis from this, and prognosis is similar to conventional SCC. Acantholytic SCC has a nest of cells with the center of this nest showing separation of the cells from each other. These all the cells show features of anaplasia. It is non-metastasizing, but local recurrences can occur and may progress to conventional SCC. Adenosquamous is more aggressive than conventional SCC, and propensity is for recurrence. They might be local and distant metastasis. It is called adenosquamous because they will be nest of cells, but these nest of cells will be showing holes or lumens. So that gives it a glandular appearance. So adeno refers to glandular, squamous refers to the rest of the squamous elements. Lymphoepithelial carcinoma, so there will be pale malignant squamous cell intermixed with lymphoid population. So this is rare in oral cavity, but it will present as high stage. 70% lymph node metastasis can occur. Some cases are Epstein-Barr virus positive. So this finishes our oral cavity pathology. Thanks for listening.